Hello, everybody, and welcome back to another episode of the Enhanced Pod. Now, today's episode is brought to you by HiTech Therapy, South Africa's trusted supplier of all your rehabilitation equipment and consumables, as well as clinical technology. We have also proudly partnered with STORZ Medical. They are the global leader in shockwave technology and evidence-based shockwave therapy at that. So, thanks to STORZ, we've got an incredible guest today, Mr. Paul Hobrough. Paul, did I say that? Did I say your surname correctly? I hope I didn't butcher it.
Pretty much. It's like the way you pronounce it is like cobra, the snake cobra, but with an H. Hobrough.
Got you.
Yeah.
Paul
But I've had
Hobrough.
every version of it in my life, so don't worry.
Now, ladies and gentlemen, Paul is a highly respected physiotherapy, not just in the UK, but globally as well. He is an educator. He is a published author. He's an international speaker, and he's got extensive experience in musculoskeletal rehab. But specifically, he is a global leading expert in shockwave therapy. So we are going to be speaking all things shockwave and leaning on Paul's insights, and we are specifically going to try and apply it to some of the challenges that we have in South Africa and see if we can flip the script and shift our paradigms here. So, Paul, how did you get into shockwave therapy as an interest?
So I was a very hands-on interventionist physio in the first place, and I had someone, when I was first setting up my business, walked in through the door and said, "Can you help me with my plantar fasciitis?" And I just quoted chapter and verse and said, at the moment it's a self-limiting condition. We're talking late 1999, early 2000s. And I said, it's self-resolve in 18 months. There's not a lot we can do. Here's some exercises, and he turned around. Well, I won't tell you exactly what he said, but he said, "That's no bleeping good. I thought you could help me." And it really sat with me because, and I thought, well, there must be something. So I researched everything that was around, and shockwave therapy came up. Plantar fasciitis is one of the key interventions that shockwave is sort of known for. And I read all the research, and like many at that time, I went, yeah, it's kind of, some of it's good, some of it's bad. I didn't really have the money to invest at that time. So if you like, my thinking went more down the route that it's bad because I couldn't have it, so it must be bad, or I don't understand it, so it must be bad. And then a few years later, I was privileged enough to be working with, the top female marathon runner, Paula Radcliffe, and she said, we really must look at shockwave, Paul, for her Achilles. And I said, you don't want that. Shockwave doesn't work. I read all about it. And here I am negotiating with the world record holder, Olympian, the most notable runner in the planet. Here I am as a physio, almost trying to tell her what to do. And she said, "Trust me, I've used it. It's brilliant. You need to get on board with this." So, okay. I spoke to a company here in the UK. I asked if I could use a machine, and I got my hands on it. I used it with a few top level athletes. They all were so much better than I'd ever experienced before. And I went, my God, something's wrong with this science I've read, because in front of my eyes, this is really working. And then I bought that machine from the supplier. This was, I don't know how long ago, 20 something years, and I've just gone from strength to strength with it. And so much so I wanted to learn so much about shockwave, because I had this difference of opinion between what I was experiencing and what the science was telling me. I couldn't find anything, so I wrote a training course for it, and that's probably what launched my shockwave career internationally.
So, I think a lot of users or potential users as clinicians will identify that story with you kind of cherry pick the science and you create this narrative about why you don't have it or what it does and doesn't do. Can you maybe just give us the 101 crash course on what exactly is shockwave therapy and why does it work?
Sure. So, what you're leading into there is people's confirmation bias, right? Oh, it doesn't work. It's expensive. We're ripping people off, all that sort of stuff. So fundamentally, I used to come at this from a very, defensive about shockwave, and you've got to understand it. And I'm far more scientific now, right? There's good and bad research about shockwave. If you want to find the bad stuff, no problem. You can go and find it. I don't have a problem with that. My job here is not to convince people that it works. My job is to give a balanced overview of how we think it works. So, number one, mechanotransduction. Mechanotransduction, people will be familiar with this from heavy weight training. There is a mechanical impetus into the tissues in the body. Your body responds to that. So what we're doing with training in mechanotransduction, by doing some heavy lifting to build our quads, for example, is we're sending a stimulus to the body that we want it to be stronger, and your body then responds biologically by saying, okay, we understand the demands, we're going to build you stronger. Fundamentally, when a shockwave enters a human tissue, human cells, it is stimulating that biological response. Now, we can really get into the woods and start talking about VEGF and interleukin 6, 8, 10, and how they respond. But fundamentally, if you want to break down shockwave therapy, we are stimulating and differentiating your stem cells. We're stimulating fibroblasts, we're stimulating osteoblasts to regenerate and rejuvenate soft tissue, bone tissue, so much so that they're now using it on brain cells, they're using it on heart cells, they're using it on skin cells for scarring. So we've pretty much now got a broad-based understanding that if you aim shockwave therapy at a human cell, it will respond positively if you get the right dosing and you're getting the right position of the tissue, if you like, acute, subacute, chronic, and so on.
Got you. I know we are condensing quite a complicated topic into some basics, but
Yeah.
I think once we get through the whole conversation, I think it's going to make a lot of sense to people. So let's continue on this Shockwave 101 journey. And I think words that people might be familiar with is radial shockwave and focused shockwave. So we now have a little bit of understanding around the physiology. Now, what is the difference in the two devices and their application?
Yeah. So people like to have them compete, right? And I think that they do quite different things, but there is this crossover. So fundamentally, radial shockwave therapy is the one that most people start with. It's a cheaper model to buy. It's got less contraindications. Essentially, the radial device is a bullet that fires up and down inside a chamber that hits upon a range of different applicators, and it has a rapid half-life. So what we're trying to do is to generate a wave. It's now been classified more as a pressure wave than a shock wave, that hits the skin, and we try and get as much of that deliverable energy from the device through the skin into the muscle tissue. It's radial because it fans out over a slightly wider distribution area, and it's much more superficial. So I like to think of it as the ultimate soft tissue engineering machine. I did my PhD on the radial device. I love it. Some people are kind of moving away from that and saying the only true shockwave is focus shockwave, which is like needle specific. Okay. And the difference with focus shockwave, well, there's different ways of creating a shockwave, but in the STORZ Medical device, it's an electromagnetic coil. So it builds up the energy, and then that then fires across the tissue that you are dealing with to a certain point. So in other words, if I aim it like a laser pointer, not therapeutic laser, but like a laser pointer, and I point that at the building out the window, I can create the same light distribution to the side of that building as I would do here. With a radial device, the light would be getting smaller and smaller, like a light bulb. Yeah, so it's darker in the corners of the room. So I can effectively take the energy on the device with the focus device over a very narrow distribution and deliver that to the target tissues. So the best way of thinking about this is, if I were to want to treat a whole quadricep, then the focus device would take me half a day. to give the same kind of energy distribution because it's such a vast area, and I'm doing in these little needle pinpricks all the way along. With a radial device, I'm showering the energy all across that muscle. I can do it in about 6 minutes, but the depth to which I get is going to be reduced. So typically, if you think about the body as a dartboard, and the bullseye is your pathology. So for now, let's say that's a mid-portion Achilles. Yeah. We would want to use the focus device directly over that point of pathology and the radial device around everything else around that dartboard. So the gastrocnemius, the soleus, the plantar aspect of the foot, along the length of the tendon, because we can cover a large area in a short amount of time quite superficially with the radial. The focus device is getting straight into the nuts and bolts of it. We can get high energy, deeper, and that tends to have a higher therapeutic effect on the target tissues. So you can just use one or the other, but you've got to drive the radial machine a little bit harder in order to get it to work that pathology. The focus device, I wouldn't want to treat a large area, but if we're talking about pinpoint pathology, calcific tendinopathy of the shoulder, brilliant. So what are you using it for would be my choice of machine. And actually used in combination, like I just explained, is probably the secret sauce.
That's such a great clinical analogy, Paul, and I think you've explained that really, really well. And I want to just ask, like you said, that you can treat different pathologies with both. I think you gave a great example there with the quad or with the Achilles tendon. Is there anything wrong with if clinicians are deciding between do I go for radial or focus shockwave? Can I treat a broad spectrum, for example, with the radial, if I've got that calcific tendon in the shoulder, as an example?
Yeah. So if you get into the research, there's I'm a bit of an anorak with the research, so forgive me, but there's a paper by Hussein in 2015 that looked at treating frozen shoulder purely with the radial device. Now, everything I've just said would suggest we're not going to get enough energy. You're going to need the focus device. It would be my go-to machine. And yet he showed a fantastic result using radial pressure wave on a frozen shoulder. So there are lots and lots of instances where you could say radial really does a great job. And I think as an introduction to the shockwave world, that's exactly where everyone should start. You've only got 2 contraindications, not over a pregnant tummy and not over a primary tumor. Apart from that, go for your life. Yeah. So it's very, very safe. Second of all, we're starting to learn that the use of radial pressure wave, for example, you will struggle to find studies for mid-portion Achilles tendinopathy where focus would be radial. You'd get a fairly equal result. But if you go to the insertional Achilles, you're going to find that focus shockwave, which is the only one that can really treat bone, which is a huge differentiator that I forgot to mention earlier, only really focus shockwave is going to work on something like a insertional Achilles. So there's a broader spectrum, shall we say, of things that you can go for with the radial device, but it really depends upon your patient group. If you're dealing with lots of arthritic joints, if you're dealing with much deeper structures, you want to try and break up calcific deposits, you're going focused. If you're treating, let's say, more athletes where you're trying to get them back performing quicker, it's basic superficial tendons and muscle work, you're definitely going to want a radial device. So your patient group will probably dictate which one you go for first. I think that when you really get into it, you end up like me, where you've got the radial device, the focus device, and something called EMTT, which is an electromagnetic machine. And then you're using all 3 in a complementary way. But for the listeners to this podcast, I came to South Africa a couple of years ago, and I don't mean this to come across in an unkind way, but I felt like the thinking there was a little bit behind where we were, and people were very suspicious of shockwave. They didn't automatically know the difference of the 2 machines, or even know the 2 machines existed. And and it's been my passion since then to try and find a road to come in there and maybe spruce things up a little bit, right? And I know that each country has its different cultural approaches to the way healthcare and particularly physiotherapy might govern, but I think there's a fair bit that we could increase the knowledge, shall we say, around shockwave, for good or bad. And for those people that want to still say it doesn't work, it's not for me, great, let's have the conversation, let's talk. Yeah.
I think that's why this conversation is so important, Paul, because I've been on the same journey as you, and trying to be a scientist and be objective and to be open to different research, treatment technologies, modalities. I think it's our clinical prerogative to keep an open mind and keep reviewing the evidence as it surfaces. And for me, I'm seeing enough evidence to say, okay, this is something that as physios, even though maybe in South Africa we're a little bit behind, it is something that we need to explore. And it starts with having conversations and chatting about the barriers as we are here. Now, I want to hear your thoughts. I think you've given us a great description of the devices, some of the physiology of how it works. I want to just ask, for the clinicians that struggle with, okay, we want to throw away manual therapy and we want to only be exercise based. That kind of doesn't leave room for these sort of devices. So we play ourselves into a corner there. My personal belief is, even as a sports clinician and rehabilitator, we need tools that enhance the manual effect. Because if we throw that away completely, who's going to pick up that piece of managing the acute or subacute athlete? So what sort of discussions do you have around how to apply shockwave with other evidence-based modalities, whether that's technological based or even if it's exercise?
Okay, so there's been a huge move, particularly on the internet, with people who are growing in personality online, talking about passive therapies. It's charlatan, it's snake oil. What we should be doing is the biopsychosocial model only, and then giving squats, more exercise, do more exercise. Listen, strengthening someone up is a great way to help them. That there are some phenomenal studies that link shockwave to loading, and we can find the two together. The sum of their parts is greater than the individual components. But just to go back to this seismic shift we've had, particularly with younger physios who are perhaps a little bit more impressionable and are hearing that, oh, I mustn't be an interventionist physio, it must only be around exercise prescription and biopsychosocial model. First and foremost, I've never seen a physiotherapy degree, master's, PhD, which teaches us how to be a psychiatrist or a psychologist. And yet everyone seems to immediately, in the last 5 years, believe they are that. And they start talking to people about how their brain is, oversensitive to pain. And I think if we're going to say that the human body needs the biopsychosocial model, I'm not convinced that the physiotherapist is the right person to be doing it, because we simply don't have the training. That's the first point. There is a huge segment of patients, particularly that find themselves in the primary care settings, who have erroneous views around, oh, my knee's going to be bad because my dad's knee was bad and his dad's knee was bad. And on my mum's side, they all had heart issues, and so that definitely means I'm going to die of a heart attack. And these people need educating, and education is huge around what musculoskeletal pathology actually is and whether there's a high likelihood that it's come from these erroneous views that they've got. My spine's crumbling. We need the education piece. What I think is a problem is when we start becoming pseudo-psychologists. And so I see a lot of people in my clinic, because I'm still interventionist. I get called a fossil daily or a dinosaur, and that's fine. I'm completely fine with that. I call it throwing the baby out with the bathwater. We've got decades and decades and decades of solid research about manual therapy and interventions that work. We don't have all the answers. And of course, I'd be upset if there wasn't negative science as well as good science, because when you really understand how to read scientific papers, you should know that why that paper says that it doesn't work, not just let that lean into your confirmation bias. And I really love the biopsychosocial model. I read the science on it, and I can find flawed science, and I can find science that's really good. So when a patient is there in front of me, I want to treat that patient. And I know that biology plays a part, and I know that shockwave influences biology. So if I have a patient in front of me that has an issue which requires, in my belief, an intervention in their biology, I can look at, can I do that by exercise? Can I do that by shockwave? Is there any other manual intervention that I might use? I'm not rubbing tree bark on them. I'm not, throwing darts at them from the other side of the room. What I am doing is looking at the problem and treating the human in front of me and the problem. So it isn't one sort of rule fixes everyone. You have to treat the patient. So there's room for everyone. And I don't believe that anyone should be so binary as to be on the internet saying, all that stuff doesn't work. It's all crap. We don't believe in it, because and citing studies to say that, because we are moving at such a pace scientifically as a healthcare across surgery. I mean, just look at meniscus surgery 5 years ago compared to now. Everything is moving at a huge pace because we're in relatively new science. Something comes along that plugs in the wall and is expensive, and you charge people for it, and everyone starts, going crazy that it must be a charlatan, it must be a terrible thing, rather than looking at it objectively as you are doing now, Nick, which say there's probably enough of a signal here that something is happening quite well. And if you pick the right patient at the right part of their journey, I think this as an intervention alongside education, alongside whatever lifting regime or graded exercise program you give them, creates this amazing Venn diagram where the patient is at the center of it and my ego or someone else's ego is outside that circle. We're just doing what's best for the patient. So integration is everything about my practice on a daily basis. What I will not do is pretend that I'm a psychologist.
I think you've hit the nail on the head there, and I think we need to be careful about turning these complex, nuanced topics into very polarized kind of outcomes, because then again we kind of label ourselves as I'm an exercise-only physiotherapist or I'm an interventionist, as you kind of nicely put it. Again, don't throw the baby out with the bathwater. Let's be a little bit more pragmatic, because I think the reality is this: you've worked with elite athletes, I've worked with elite athletes. Try tell someone aiming for an Olympic gold medal that your only intervention is exercise and taping, for example. That's probably not going to cut it. Try tell that to the person that's pitching up to your practice in pain, like you said in your example with the plantar fascia, that it's self-limiting, it's going to come right. That's kind of contrary to the business of helping people improve their health outcomes. So I think we need to be a little bit more clever and intentional around the way we discuss these, and let's not put ourselves into these corners where we can't back out, because I think there's a lot of people that are trying to back out of the whole exercise only option now, because you realize, whoa, in real time it might not be working the way that we thought it would. Paul, I want to segue from there into, I think we are addressing some of the challenges that a lot of clinicians face, and that we almost need to get our heads around when thinking about shockwave. But a big part, and I want to lean on your business knowledge and expertise and your business coaching, business mentoring, physio specifically in this space. I think people struggle with, how do I figure out the economics of integrating shockwave? And we've spoken a little bit offline previously about this topic, and it's a real paradigm shift for physios to think about, well, I'm not just selling my time for money. It's more than that. It's a value proposition. How do you coach physios to kind of get that across? Okay, I understand how shockwave works. I feel like I've got a lot of patients that can benefit for it, but now I need to figure out the economics.
Yeah, so there is a problem with physiotherapy, in that people come in, and if you are not educating the person correctly on what you do. They start looking at their watch if you're done in 15 minutes, and they said, but I thought it's a 30-minute appointment. So in my opinion, hookers sell time for money, physios sell results, right? I do not understand this concept that a patient would ever say to me, but there's 5 minutes left. I'm like, what are they there for? I'm not a massage therapist. If you want to sell your time for money and you're going to say, I've got a 30-minute, 60-minute, or a 90-minute massage, go do that. But call yourself a massage therapist. And there is a world where that exists and is a highly successful business model. But I always say to people right at the outset when I start their business mentoring, people don't buy drills, they buy a hole in the wall. So if I want to hang my TV, I don't care whether it's the tail of an aardvark that makes the right hole, as long as I can hang my TV. I want the end product, right? So for all the people that are going into practices and having that problem, they're still selling the drill. Sell the hole in the wall. What is this going to do for my patient? A patient that is well educated on what their journey is going to be, where they are now and where they're going to, is going to be a really compliant patient in whatever treatments you're putting forwards. But if you start the process by saying, this session's 30 minutes long or 60 minutes long, that's the metric you're now working to, not getting a result. So when it then comes to charging for your expertise, you need to think like the fable of the old engineer, which I'm sure many people have heard of, but just very quickly, if we've got time. Let's say it's a big ship. This ship will earn, $1 million by, taking people around, fantastic islands, and it's broken. So bring this old engineer, the only guy that can fix it, and he comes in with a deck chair and a hammer, and he sits in there for 2 days reading a book in his deck chair, and every now and then he comes and hits something with a hammer, and lo and behold, 2 days later the boat works. He submits his bill, which is $100,000. Yeah. The person who gets the bill goes apoplectic and says, how on earth? All we've seen you do is sit in a deck chair and read, and every now and then hit something with a hammer. I need you to break down your bill. He said, no problem. He said, it's £9,999 for one part of my expertise and $1 for the other. $1, you're right, is for hitting things with a hammer. The other money, everything else, is for knowing where to bloody well hit. Never question me again, right? So the point is people are paying for your years of training and expertise in that moment to accurately identify what's wrong, test correctly and sufficiently so they know what's wrong, the state of your tissues, and what the most likely diagnosis is going to be, and therefore what we're going to do to treat it. That is where your financial reward comes from. And if you believe that you are only worth, I don't know, 350 Rand or, 200 Rand or 1,000 Rand, then charge that. But if you genuinely believe that you are a very, very competent person, you can charge what you like, because people will pay for quality. I charge at least 5 times more than anyone else in my locality. My books are full, theirs aren't. That the people aren't price sensitive, like that's the excuse that everyone gives themselves. Yeah, it's just they don't understand. You haven't educated them about why you're different, about what you're doing, and about how you're going to help them. So my hole in the wall is about, okay, this is where you are, this is where you want to get to, this is my roadmap to get there. I think it's going to take us 6, 8, 12 weeks. These are the things we're going to use, and this is how much that's going to cost. I never once say, well, my time is this much. If I, give you a stretchy band, it costs this much. If I use Shockwave, it's this much. This is the cost for you to go to A to B. And no apology, lots of eye contact. I'm confident that I'm worth it. If they pick up on that, they're going to go, hey, I understand the rules of the game. Here's my money. Now, not everybody is going to be in the right position financially to do that. That's fine. So you're going to have tiers of healthcare providers, and the people are going to select where they want to be. all of your listeners can go to hobrough-healthcare.com, if you can spell my name. That's my company. And the first words that hit you on my screen are something along, I paraphrase, if physio hasn't worked for you, if you've traveled around trying to see everyone else and you're lost and you're stuck and you've spent money elsewhere and it hasn't worked, this is probably where you need to come. I am not someone that's just hurt their back in the morning should be coming. It's not complex enough for me. They're overpaying for that very simplistic approach. So decide where you sit in the market and price yourself accordingly. And if you explain what Shockwave is going to do, and your patient understands that extra bit they're going to get. So it's how you explain it. It's a plug-in modality with an 82% success rate that will literally stimulate and differentiate your stem cells. There are studies that show a 50% faster return to play because they've used Shockwave. At the moment, I think it's the best route for you, but it's going to cost you X. Off we go. They then understand if you're giving that away for free, they don't value it. You've wasted your money. It might still work for them, but you're now, I mean, buy everything by all means and don't charge for it, but you're never going to have a successful business. You're always going to see profit as a dirty word, and you're always going to be struggling to pay your tax bill at the end of the year. And there's lots of physios stuck in that cycle. They'll recognize themselves in that until they start thinking, I refuse to be paid less than the person fixing a new tire to my car down the road. I refuse. I've done too much training and education to align myself with those kind of fees. And then the lights come on and we have someone that's ready to change.
I think it's probably going to touch a couple of nerves, but I think it's good that it does that, because that's probably the wake up call, or the sort of level that we need to speak to, because it's a deep rooted, I want to say, fallacy or misconception around the value of physio and this altruistic, it's we're healthcare providers, we shouldn't be profitable businesses. And I think that kind of puts an extra obstacle in the way when someone's considering, okay, well, maybe I'll just offer the service and manual therapy and exercise, and I'm going to protect myself by not investing in Shockwave because I'm worried about the financial implications, or I don't believe in myself to be able to sell it or to show the value of it in return for financial compensation from your patients. But it's a value and a service. It's not not that it's not a charity. It's not we've got to give ourselves to the detriment of ourselves, if you know what I mean.
Yeah, I can't, I'm never going to be able to understand the person that thinks that they're not worthy of making some profit if they're running a business. That is pointless. Go and get a job. If that's where your sensibilities are, that you think this is an altruistic calling, I can tell you 100% of the time when I work with clinicians, one of the biggest blockages they have, and we have to get over this, is where is their lack of value coming from? With one guy, I went right back to the way that he was parented by, as a kid, that he never felt like he was worth enough. So here he is in the States giving so many more treatments, an hour and a half, to try and justify his own existence. Let me tell you, if your patient gets better, they're happy, and whatever you charge them, it was cheap. Whatever you charge them, if they get better. However, if patients are regularly not getting better, then you're going to start to think, is what I'm doing correct? Now, you can't expect to fix everyone. I think, if you're hitting 75% of your patients, you're probably doing a reasonable job. And that's good and worthwhile, because no surgical intervention, no medical intervention, nothing has a 100% success rate, right? So if you're going to live or die on the ones that didn't work, then you perhaps don't understand healthcare or the human body, right? But if you are going to sit there and say it's completely wrong that physios make money or become, somewhat wealthy off of this, that is completely incorrect as well. And let me tell you, as I've built my clinics up and if you like, I've improved my standard of living, for want of a better word, through my work, I am far more likely to turn a patient away that is an inappropriate referral to me. I'm far more likely to say to that person, you know what, I can see you're down on your luck. They can't afford to do it, and treat them for free where it's necessary. But you know what? Most of the people come in, it's not even a question about the cost. They've heard about you. They come in and they get treatment, and everything is based upon success. So I'm not now in a position where actually I perhaps need to work to make the mortgage payment or whatever, and that puts you in this lovely position, and you help the patient the best possible way, in the most altruistic way, if you like. But yeah, there's a cost attached to it, which everyone knows about. It's advertised everywhere, and I nor the patient has a problem with it, because it's an exchange, and people would pay, in the UK terms, £18,500. I don't know what that refers to in rand these days, but to have elective private knee surgery. Is that knee surgeon a bad guy because he just took 20 grand off you to fix your knee? Everyone understands business, So I'm never going to understand that thought process. But I've seen it in many countries before. We've helped them turn it around, and no one's ever sad that they changed the way they think.
I think it's great for you to highlight from international experience that it's a theme and topic that comes up with physios across the world, and we'll probably do our
Everywhere.
heads in. We'll do our heads in trying to think, to the roots of why that is. But I, as a physio business owner myself, I like the way you speak about it, because I agree. I'm trying to provide for my family, send my kids to school, have a quality of life that requires my business being somewhat successful. So these are things that we need to speak about. Paul, to kind of wrap it up together, ladies and gentlemen, if you didn't know, Paul's joining us from Madrid in Spain. So we had a bit of a time difference disconnect, but he's currently attending a global shockwave conference where he's actually speaking. Yeah, so there you
Yeah.
go. So he is someone that's very, very, very involved in this modality globally, and as I said previously, an expert. Paul, your advice to an interested clinician who's made it this far in the conversation, who's kind of chewed on the glass of some of the discomforts of our beliefs that we need to work through. What advice do you have for them when considering shockwave?
So my advice would be, start again, start afresh, start looking at the data through a different lens. Imagine that I was personally going to gift you all the machines. You had a radial, you had 2 radials, 2 focus now. You knew how to use them. Now go back to the literature and take away the, oh, but this guy online says it's rubbish and it doesn't work, and I've read this. Just refresh yourself. Imagine it's there already, and go and pick out some literature. Don't just read the abstract, read the whole thing. Start to learn some of the terms around the different energy levels and the number of times that people are treating, and start to look at studies and go, oh, well, this one did work, and they did 6 sessions at a high energy level, 1 week apart, and they followed up 3 or 6 months later to see the result. That's a kind of good methodology. Or this one over here that did 1 or 2 sessions at a very low energy, they followed up after 2 weeks. Now they say it doesn't work. That's a poor methodology, right? So we know that shockwave is trying to interrupt and induce some sort of movement with your biology. That can take at least 90 days for collagen and protein synthesis. So start reading the research with a different lens, a bit slightly more balanced view. Don't take your baggage with you. See if you can speak to a manufacturer about even getting a machine on loan. Charles will probably kill me for saying that, but or find a local clinician where you can go and see some. Seek out patients that have had shockwave. Look on forums. How did they like it? Because that patient voice is far stronger than someone with a bit of confirmation bias over here that wants to push their agenda on what they're doing. Yeah, I'm trying to be really open. And if they started there and they got their hands on a machine and they watched their patients develop in front of their eyes, and they saw their patient satisfaction scores go up as everyone does when they get the machine, and they start to see this additional revenue stream coming in, which isn't a bad thing. Yeah. then they start to build a whole different picture. One thing sounds a bit like a plug, but if anyone's on LinkedIn, the ESWT hub, so Extracorporeal Shockwave Therapy Mnemonic, ESWT hub, is a group that I run on LinkedIn completely for free. And I put new videos on there all the time. They're short, 2-minute, 3-minute videos, and you can get lost in a sea of all that stuff. You might get bored of my voice, but that's a free resource where you can go and look at this stuff and hear what I think about different studies if they're interested in building that sort of next step on the ladder. And if you don't like it, don't use it. But you don't need to go around telling everyone else that it's crap to make you feel better about yourself. Just go, it's not for me, put it to one side. And you know what? We won't come along and say that just doing squats for every condition is bad. And, I think the far more integrated approach. We're all physios and we all seem to be online fighting each other, which is confusing for the patient, and we only do all of ourselves a disservice. So it's one big happy group hug family around the world. Here's something else. If you want to try it, get to know it first. At least shake its hand before you decide you don't like it.
And Paul, what I'm going to do is I'm going to put the link to that ESWT hub group in the episode description. But I just want to say thanks for sharing your knowledge and your insight. Thank you for challenging a lot of beliefs. I believe that we'll have existing shockwave users and interested prospective shockwave users on here. And as we said in the beginning, reach out to HiTech, Charles, and the team. Have a look at STORZ Medical, who have been associated with putting this episode together and bringing us an expert like Paul. So, ladies and gentlemen, this is definitely something that is, it's been around for a long time actually, but in South Africa, we're starting to see this conversation gain a lot more traction. So it's something that is highly topical. Educate yourself before you make a decision, but look at it with an open mind. I think that is our takeaway from today. Paul, any final words before you get back to your conference?
No. Well, I guess I always like to say that where we are in the world of healthcare is that as the more you learn, the more you realize you don't know. Yeah. And so I always like to have a really open mind. And so I'm here at the International Shockwave Conference in Madrid, and I go to other conferences where I'm not speaking, and there are things that I don't necessarily believe in or agree in, but I love hearing people that are passionate about that talk to me about it and try and convince me. And if they can't, they can't. If they can, then I perhaps sometimes change the direction. But I love to be challenged. I love to challenge. And I think that's how the conversation moves forwards. We can all have a big group hug and just talk nicely about stuff. But I genuinely think that the only way that science moves forwards is with a bit of challenge here and there. And I love being challenged and I love challenging. And I hope that we can do more talks like this, Nick, where we can get into the nuts and bolts. We've highlighted some key areas there. The whole business model stuff is, that's a whole hour in itself. Talking about the fundamentals of shockwave could be another 40 minutes. So I love the fact that we're back talking this way with South Africa through you. And that's how, we get to the audience. And I love the fact that we can engage in those conversations, and it's my best day ever when someone says, you're full of shit, and then we can have a grown-up conversation about it. So I invite that, if you will, because I think it's a phenomenal way for everyone to learn.
100%. I think just from the podcast platform, I think we believe that discussion and debate is healthy, and it's good to have opposing views if we can all be adults and listen to one another and be willing to change our mind when presented with the right evidence. So I think you've highlighted in your story around shockwave, you've come 180. I'm in transition currently, and I've got no reason to be on either side of this fence, but I'm interested in seeing the conversation, and I appreciate the challenging on beliefs that you've had. And I would love to follow up and maybe dig a little bit deeper into the business parts, the psychology parts, the how to help physios think differently around their business models and structures and integrating devices like Shockwave. But we're going to park it at that for today. And I think we have set it up so beautifully for sequels, follow-ups, and I think there's the possibility that you might be coming out to South Africa later in the year. So I think people will get to debate with you and have their world's views changed in person as well.
Or my worldview changed. I mean, you never walk in a room and come away more stupid than you went in, right? So, but I think I feel a lot of hope around this. And, you know, when we did our road show a couple of years ago, it went down very, very well to some relatively small groups. And it'd be nice to see that grows and we get some bigger volume of people coming along to have that discussion. But yeah, October is what's been talked about at the moment. We don't have a firm date, but we travel around, you know, like Johannesburg. We went to Cape Town, and I think we went to Durban last time. So yeah, I'm coming to town. So let's get involved.
Absolutely. So, Paul, we want to just say thank you for your time. Good luck with your presentation at the conference. We look forward to seeing you and meeting up with you and discussing more when you're in South Africa in October. And again, to wrap up, thank you to our partners for this episode, HiTech Therapy and STORZ Medical. We will see you in another episode soon. Thanks for your time.